things. This is my first Zoom ever, so hopefully there won't be any big snafus, but we'll go nice and slow. A couple of things. I want to kind of echo that back. I think that hopefully the residents at UCSD are aware of how fortunate they are that their department supports this clinic. There are other regional Hansen centers in the US that don't have the same support, which unfortunately has closed, which loses a teaching opportunity for residents, but also creates great inconvenience for patients. The clinic in San Francisco closed, so those patients are driving to LA or Seattle. So that's a big issue. And so a couple things. I'll go through these slides pretty slowly. We're going to go over some basics, and then we're going to be joined by Dr. Ali Cantabellian, who is a derm applicant, and she's currently an intern up in LA. So she's going to present one of our super interesting patients kind of halfway through my presentation. I think today we also may be joined by a few derm residents from Vanderbilt in Nashville. This complicated patient that Alik is going to present moved from San Diego to Vanderbilt, and so is managed currently by Dr. Miller. And so that's how that Vanderbilt connection happened. Yes, I grew up in San Diego. I did my derm residency at UCSD many years ago, 93 to 96. And I'm a clinical dermatologist at Scripps, kind of Monday through Thursday. And then I do this clinic on Fridays. And I really enjoy it. I think Hansen's is super interesting. And I do think it's really an underserved population. And I think, we not only function as dermatologists, but I think we quasi-internists and social workers, and there's a lot of things going on with these patients. So let me go over a couple of things here. I just want to say one brief thing about Dr. Pades, who I think some of the residents know and the faculty know. Frank was a dermatologist here in San Diego for a long time. He was my dermatologist growing up as a kid, and part of my inspiration for why I chose this field. He trained at Mayo. I think he retired, and then he really wanted to go back to teaching. So we went back, got his medical license, and I think he was an attending at the VA for 8 or 9 years, and he just passed away recently. So just wanted to say a brief thing about Frank there. So what we're going to talk about today is the history of this disorder, some of the different subtypes of leprosy, the medications that we use, the dosing regimens, susceptibility, diagnosis, lots of different things to cover. I think the main focus of our clinic is that I want a derm resident to say, hey, this could be Hansen's, know what the cardinal signs are, to raise the suspicion of, yes, this patient needs a biopsy, I need to do some labs. I don't think anybody's expecting a community dermatologist or a derm resident to manage these really complicated reactions, but I think our goal as part of the teaching is to just have it on your radar, what kind of things to look for, both as dermatology signs and non-dermatology signs, and how to at least start the workup. And I think we've been very lucky with that. I just had a patient who ended up with one of our former residents, Dr. Cotter in Las Vegas, and he called me and he knew what he was doing, and that made me very proud. So that's great. So what is leprosy? It's a disease that has been around forever. There's records in the Bible, there's before the Bible. It's a really stigmatized disease in certain societies, which we'll talk about. The organism was discovered by a Norwegian dermatologist, Dr. Hansen, and that's why in most of our patients, we call it Hansen's disease and not leprosy, because it's a little bit less stigmatizing. It's caused by this bacteria, rod-shaped bacteria called Mycobacterium leprae. It's very interesting, and we'll talk a little bit about that. It really only grows in human beings and armadillos. The things that make it interesting is that it has a really long replication cycle. It takes forever, and it grows at a lower body temperature, which we'll talk about. So a lot of the research that we do, the studies, are based on these 9-banded armadillos. This is the organism with a fight stain. I also want to give a little bit of shout out to Brian Hines, because we've had some significant delays with the processing of both our skin smears and our skin biopsies that we're sending to our headquarters in Baton Rouge. So Brian has been kind enough to offer to kind of be a backup and a double check on some of these. So I appreciate that, because for some of these patients, obviously making a diagnosis as soon as possible is important. So we talked a little bit about this, and I think the big issue with these Hansen's disease patients is that many of these patients may have been exposed 10, 12 years ago, and it's not until a real long lapse of time that this disease appears. And so that's one of the things that's very interesting about Hansen's. In terms of, who's at risk for this, there's countless studies that have been done about if you have a mom with 8 kids, why does one kid get it and nobody else gets it? So there's a lot of questions about nutritional status. Is there some type of T-cell dysfunction? What is the exact trigger? And that's a little bit unclear. We'll talk more of this in depth, but it does affect other organs other than just the skin and the nerves, and we'll talk about that. So again, who's at risk? And it can be very unusual in its presentation as well. I mean, you can have a patient who has just one of these small lesions that's like P. alba, or you can have a patient that shows up with really, really advanced disease, such as this patient here. Where is leprosy found in the world? I think our 2 biggest populations currently are in Brazil and India. I would say that the majority of the patients in our clinic are coming from Mexico, Philippines, Burma, Vietnam. We've had a few endemic cases, but not many. Leprosy is divided into the classic Ridley-Joplin classification, which we'll go over a little bit, which basically defines people in terms of being either tuberculoid or lepromatous. And a lot of that has to do with the amount of bacilli that they have and their immune system's ability to react to those bacilli. And so a lot of this diagnosis is based upon skin biopsies. The other thing we'll talk a little bit about is that in these patients, this classification can be a little bit cumbersome and complicated. So in an attempt to try to facilitate this, to make it a lot easier, a lot of facilities around the world now are basically just dividing patients into being multibacillary or paucibacillary. So multibacillary patients are those that have lots of organisms. Therefore, they have a much higher incidence of reactions, et cetera. And then the paucibacillary patients as well. This is a great, I think, slide for the residents. I stole this off the internet, but I thought it was great, which really talks about the fundamental differences between tuberculoid leprosy and lepromatous patients. And a lot of it really has to do with how your immune system is working. And one of the things that we'll talk about later is, in addition to tuberculoid and lepromatous patients, we also talk about reversal reactions. And then we also talk about this other thing that can happen, which are upgrading and downgrading reactions, which are very interesting as well, where the status of patients' immune systems changes and then their reactional states change as well. So cardinal symptoms, and we're just going to break this down into PB and MB patients. So PB patients have just a few small, well-defined skin lesions, which are either anesthetic or hypoaesthetic. Multibacillary patients, because they have a higher bacillary load, tend to have other organ involvement, which Alif will talk a little bit about as well, but usually multiple skin nodules and other organ involvement. In terms of, our goal in this clinic and my goal as a leprologist here is to really help not just derm people, but just physicians in the community to try to keep that diagnosis on the radar. Because if you're able to do a biopsy and give somebody a diagnosis early on in the course of disease, it can be life-changing for these patients, because we see many patients a year where they've had this rash in their arms and their fingers are kind of numb, and they've been to one doctor, another doctor, and they just keep getting, topical steroid creams and nothing's getting better. And by that time, a lot of them do have some permanent sensory loss and other issues. So one is really early detection, appropriate treatment. And then a lot of the stuff that we do in our clinic is wound care in terms of ulcer debridement, that kind of stuff for those patients who unfortunately have had some sequelae. Stigmatization, we talked a little bit about as well. It's very interesting because in certain cultures and societies, it's not that big of a deal. I have a Mexican family where grandma, the aunt, and the granddaughter have all had it. It's not too big of an issue. I have other patients from other cultures. I had a woman who was from Cambodia, young woman, and she had these patches all over the place, and she never told her husband within a 3-year period what she had because she felt that that would be an immediate reason for divorce. So it's differently perceived in different cultures. And a lot of it is, patients who are willing to talk to their family about it is, our nursing staff is involved in that discussion process as well. We also refer to our patients as HD clients or HD patients. We don't use the word leprosy in our clinic. In terms of pharmaceutical treatment, I think many of you are familiar with some of these medications. The standard drug therapy, we just call it MDT, multi-drug therapy. And the medications that have been used for quite some time in this combination, which we'll talk about specifically, dapsone, rifampin, and clofazimine. So the mainstay of therapy for many years has been dapsone, was discovered in the early 50s. It works well for this condition. There are obviously some potential side effects that we'll talk about. And I think that a lot of the derm residents know that I use dapsone for lots of different things as well. The main issues with dapsone that I think most of us are familiar with is that in those patients who are G6PD deficient, the anemia that can develop is quite profound. But even for those patients who are not G6PD deficient, most of my patients will drop their hemoglobin at least a gram, if not more. So, in an older individual whose baseline hemoglobin might be 9.5 or 10, I'm probably not going to put them on dapsone anyways, even if they're not G6PD deficient. They can develop, classic drug reactions, but there is also this unique syndrome, which is called dapsone hypersensitivity syndrome, where they develop urticarial lesions, malaise, their LFTs go up, and so that is seen rarely as well. Rifampin, I think all of us are very familiar with. It's a bactericidal agent, causes discoloration, interacts with lots of medications. And I think the way that we usually use it in clinic is that for a brand new patient, I'll have them take 300 BID for like a week. And theoretically, within 3 or 4 days, they have basically killed all of their bacilli. So if they're concerned about being contagious at all, once they've taken a few rifampin, then that's not longer an issue. So usually after a week of BID, then they just take 2 pills once a month. So it's 600 milligrams once a month after that. And then the last medication, which we'll talk about, I think, before we get to a leak, is clofazimine. So clofazimine has been around for some time. Clofazimine is thought to be an anti-inflammatory. We see it as a steroid-sparing agent. And for multibacillary patients, it's standard in their regimen because theoretically it may help decrease the risk or intensity of a reversal reaction. Clofazimine has some kind of unusual properties which are interesting. It does cause lots of hyperpigmentation with this kind of weird bluish grayish color, which seems to be accentuated in areas where patients have a higher bacillary load. So some of these patients will have random brown or red patches on their arms or face. That pigmentation can last for a long, long time. It does also stain the GI mucosa. So I do routinely have to call a GI doctor before one of our patients has a colonoscopy because it kind of freaks them out a little bit when they see that. These are the standard blister packs. And this is what's distributed through the WHO throughout the world. And you can see the PB patients have the clofazimine in there as well. In the US, we use individual bottles. These are just dosing of therapy. And then I think, Alik, are you after this slide? We're getting there, right? Okay. So in terms of laboratory studies, and I think the residents are aware of this, it's pretty simple. You do a skin biopsy, you alert the pathologist that you want them to do a fight stain because you're worried about Hansen's. And then the only labs that we really need are CBC, CMP, a G6PD level. We also now routinely are checking vitamin D levels. Vitamin D is found to be very important for our patients in terms of macrophage activation. And also, if you're concerned that they are in some type of active reactional state with raised nodules, et cetera, we'll do a sed rate because that's a good way to monitor the status of this reaction. In terms of therapy, there's always a lot of controversy about this. The standard public health service protocols in the US currently for multibacillary patients, it's drugs for 2 years, and for possibacillary patients, it's drugs for 1 year. The WHO protocols are shorter. It's a year for MB patients and 6 months for PB patients. I think their recurrence rates maybe are a little bit higher, but that's kind of where we're at now. And a lot of this therapy is individualized as well. Again, we talked about susceptibility and why some people get this and some people don't. And we talked about different organ systems that can get involved. How it's acquired, a big mystery, but usually through the respiratory tract or those patients who have contact with armadillos. I think in some parts of the South, people have armadillos as pets or they eat armadillos, so that may be part of it as well. So signs or symptoms of disease here, and I think, Alik, you stop me when you're ready.
I'm ready whenever you are.
All right, so we'll stop there, and I'm going to introduce Alik again, who's going to present a really interesting patient that I think has some good teaching points for us. So do you want me to do stop share?
Sure, I'll take over.
Okay.
All right. Hi, everybody. My name's Alik. I am reapplying into derm in the fall, and I'm really excited to be here. So thank you for having me here, and thank you to Dr. Gilbertson for including me. Let me share my screen. Give me one moment. Okay. You should be able to see it. All right. So I'll be sharing a really interesting case of unsuspecting diagnosis of Hansen's disease from a nasal swab. And 2 points that I want to highlight within this presentation are the extended timeline from symptom initiation to diagnosis and treatment. And just to emphasize, just like Dr. Gilbertson said, how Hansen's disease truly can be the great imitator and present variably, such as with our patient. So I'll jump right in. So we had a patient who was a 30-year-old white male, born and raised in the US with no significant past medical history, who presented with paresthesias of the bilateral lower extremities for 6 months. So his symptoms kind of came out of the blue, and he characterized them as this burning and tingling sensation in the anteromedial thighs, which progressed to the medial calves as well. And he seemed to have his symptoms exacerbated whenever he would have overlying clothing. So he thought it was from what he was wearing, and he would wear tights underneath to avoid this sensation that he was feeling. He had no allergies, no surgeries, was not taking any medications. And, you know, in terms of his social history, working as a financial analyst, drinking socially about once a week. So I guess the point here is he's a 30-year-old healthy male, and he was having these paresthesias. The initial workup was he was seen by neurology after a couple of months of these symptoms, and his physical exam was otherwise unremarkable. He had, like a young healthy male, he had full strength in all his extremities. He had normal reflexes and gait. However, there was a focal area of numbness over the left posterior calf with reduced light touch and pinprick. However, the patient did attribute this to, you know, probably a prior accident because he was practicing jujitsu pretty regularly. So he attributed to a past accident. Because of the distribution of his paresthesias, and how it was bilateral, the differentials included maybe a femoral cutaneous neuropathy, L3 radiculopathy. Because of the left calf involvement, it could have been a medial sural cutaneous nerve involvement or S1 radiculopathy. However, at this point, his MRI of the L spine was normal, nerve conduction studies and EMG were normal, and his lab tests, including B12, LFTs, ammonia, everything was normal. So he was told he had these atypical paresthesias, and there was essentially no further workup for this. When I had the chance to actually speak with the patient, he did note that the only skin manifestations that he was having began about 2 years after the paresthesias began. So he had 1 week episode of urticarial rash, treated with Claritin and Benadryl. He also went and had negative allergy testing at that point. And then he had a chronic rash on his trunk, which prompted his initial visit with dermatology, where he was diagnosed and treated for tinea versicolor, and that rash resolved. Years down the line, this was the point where the patient felt like his health had taken a downturn. He noticed thinning of the hair of his eyebrows, thinning of the hair over the rest of his body. He was having trouble with erections, had swelling of the hands and feet, and his primary symptom that was bothering him was nasal obstruction. So he was having, chronic congestion and frequent epistaxis that was not being helped with Flonase. So he was referred to ENT at this point, and they noted severe hypertrophy of the nasal turbinates and a deviated septum. And ultimately, it was during this surgery where an ENT noticed the atypical appearance of mucus, where you can kind of tell in this image that I provided, and submitted this specimen for AFB. So this specimen was positive for AFB, but the culture was negative for growth. And when the patient returned for follow-up with ENT, they did note particularly poor wound healing, worse than expected for a patient. So they did collect another swab. And again, it was positive 3+ for AFB with culture negative for growth. At this point, they also ruled out TB with a chest x-ray and MTB being negative for testing. But his labs, the ones that were abnormal, he had elevated ESR and angiotensin converting enzyme. So at this point, the patient himself said that he looked up, AFB, his elevated labs, and it was through his own essential research that he was convinced that he had Hansen's disease. And he did not have any skin findings, but he was referred to dermatology at this point. And during this visit, they also did not find any, skin changes, but they did send the nasal specimen for PCR testing, which returned positive for M. leprae. He was then referred to the Hansen's disease clinic in LA, and there was still an uncertainty of diagnosis here because, again, he had no skin findings, no suspicious history of travel, no armadillo exposure that he's known. There was a left forearm biopsy collected, and he was then seen at the Hansen's disease clinic in San Diego for second opinion and for slit skin smears. And it was at this point that he essentially had abnormal findings on physical exam, ultrasound, and EMG. So when the patient was seen in San Diego, he presented with metarosis, bilateral patchy loss of protective sensation to the dorsal hands and feet, very faint but hypopigmented patches on the left hand and right forearm. And he did have an ulcer to the right malleolus that was, traumatic due to a traumatic event. And he did have edema and tenderness of the bilateral hands, wrists, feet, and ankles, which are, part of those cardinal signs that we talked about. His ultrasound did show swelling of the bilateral radial, median, and ulnar nerves, in addition to swelling of the bilateral posterior tibial and the common peroneal nerves as well. And EMG at this point showed diffuse generalized polyneuropathy. So, ultimately, the patient did receive his diagnosis of lepromatous leprosy, which in the Ridley-Joplin classification that we mentioned is in that multibacillary area with the biopsy of the left forearm and the skin smears. He was initiated on the multi-drug therapy in January of 2021 with rifampin, minocycline, and clofazimine. And like we had talked about earlier, the patient was not on dapsone due to an underlying chronic anemia. And the patient did note when I spoke to him that essentially 1 to 2 weeks into his treatment, he felt like his paresthesias had improved, but he did continue to have numbness of his feet that did not change. So a couple months into that, his lab results did show that his free testosterone was low. He was in the 4 to 5 range, where normal is typically 7 to 37. And his FSH and LH were elevated. So his FSH was in 27 to 30 range, where it's usually 1 to 12. And his LH was 12 to 15, where normal is less than 12. And his ESR was also elevated. Due to the concern of, active ongoing inflammation, no response to NSAIDs, and the patient declined use of corticosteroids, he was started on methotrexate for 6 months and was put on a trial of Otezla. So I do want to kind of draw out again and emphasize this timeline, because the symptoms for this patient began in 2012 with these atypical paresthesias where, there was a little bit of workup and then it stopped there. In 2014 was when he had the only skin changes that he had, which was tinea versicolor. And then in 2016, he notes that he had numbness of the feet. But it was in 2020 where he had those cardinal signs with the nasal congestion, the matarosis, edema of the hands and feet, erectile dysfunction. And that's when the surgery took place and that swab ultimately showed it was positive for AFB. It was not until 2021 that he received his treatment. And then if you fast forward to current day, 2023, he did have a reactive episode 1 month after discontinuing Otezla in January. So he had orchitis, he had nodules on the thighs, is what he told me, and he was treated with corticosteroid taper, which ended on July 4th, and he was restarted on Otezla, and he's currently doing well. So ultimately, this case shows progressive sensory neuropathy in an otherwise healthy young male with a history of a positive PCR from M. leprae from the nose. There was, like I mentioned, there was no clear travel history of suspicion. He did have a couple trips to Mexico and Costa Rica, but just a few days at a time in very touristy areas. No exposure to armadillos. The standing theory is that he practiced jujitsu very regularly, and this involved sparring with skin contact to people from all over the world. So there were many people from Brazil and Southeast Asia. So that is currently the standing theory, but unclear. I do want to highlight that there was no improvement in his sensory and motor neuropathy despite the aggressive treatment that he has received. So my take-home points: Hansen's disease is a multi-system chronic infection from M. leprae. We talked about how it predominantly affects the skin and the peripheral nerves, but it can affect the eyes, the mucous membranes, the bones and testes, and is often misdiagnosed due to this long incubation period, these insidious symptoms that we talked about, and the challenge to recognize it in the early stages, especially here in the US non-endemic areas. So people born in the US are typically diagnosed after having known contact with people affected by Hansen's disease or with exposure to armadillos. And I think our case highlights that Hansen's disease should not be forgotten in endemic regions, and it depicts the unique course of diagnosis from PCR of a nasal specimen. So increased awareness of Hansen's disease, both by patients and providers, can result in early diagnosis and better management of care, with the goal of, preventing permanent disability. And that is it for me. Thank you so much, everybody. Thank you for having me. Let me stop sharing my screen. Thank you so much, Dr. Gilbertson. I want to also thank our patient for sharing his story with us as well.
Thank you. Thank you. Let's see. Okay, so am I back on now? Let's see.
Yes.
Can you guys hear me?
You are back on, but you might need to do the setting again where it shows the full screen for the main slide.
That better?
And then click the other option.
This one?
While you're getting that back up,
Oh,
Dr.
yeah.
Gilbertson, is Jeremy. Could I ask a really quick logistical question?
Yeah.
That was an extraordinary case. The ultrasound, is that something that is there a specific protocol that you convey to the radiologist, or do you discuss directly with them? Hey, I'm worried about Hansen's disease. Can you assess the size and look for inflammation of the nerve?
So great topic, because I just talked to Rich about if we could get an ultrasound machine for our clinic. So we'll see. But anyways, so this patient's insurance, he lived in LA and his insurance was in LA through Kaiser. And so I reached out to several radiologists at Kaiser in LA or even at USC, because it's very hard to find a radiologist who has done a fellowship in ultrasound. So there's one guy at Scripps Clinic here in San Diego that's his thing. And so I have been able to refer a few patients to him in and out of network. And he thinks this is just the most fascinating thing ever, because basically he looks at carpal tunnel all day long. So it's very, very hard to find a radiologist trained in this. On the other hand, the use of handheld ultrasound devices in a lot of clinics in India, et cetera, is relatively commonplace. Because especially if somebody has like a silent neuritis where they have some sensory loss, but not a lot of skin lesions, it's sometimes difficult to see if they're responding to therapy. You know, if their SED rate's up and their SED rate goes down, or if they have some return of sensation. But if you can theoretically quantify in millimeters how inflamed their ulnar nerve was 2 months ago to now, that helps you see if they're responding to therapy. Also, in those patients where the diagnosis is unclear, like a nerve biopsy does have a significant morbidity associated with it. So if you can make a diagnosis of Hansen's disease based on clinical exam and a positive ultrasound, there's a benefit to that as well. So I think the use of handheld ultrasonography is becoming more and more common. I think some of my colleagues and some of the other clinics in the country are starting to do that, but in many parts of the world, it's really, really common. So yeah, I don't know if there's anybody at UCSD who does it as well, but this guy at Scripps, he loves it. He's super nerdy. He thinks it's amazing.
That's great. It's
Yeah.
find somebody like that.
Yeah, so I think that the two things about the case with the leak, I think she did a great job. One is the idea that, Hansen's disease is going to affect the coolest parts of your body the worst because it replicates better at a lower temperature. So that's where the issue is in men, is because you can get testicular leprosy. It's not terribly uncommon. And the problem with this patient is that because he's had this low-grade chronic inflammation, he has primary testicular failure, and then his FSH and LH are starting to go up. And so, I try to refer him to an endocrinologist at Kaiser in LA, and it was really hard to convey to them what was going on. So that was part of the reason why I put him on methotrexate, was that if there was any residual inflammation in his nerves or in his testes, to see if I could make any of those things better. And after about 6 months of methotrexate, his feet were not any better, and the groin was maybe a little bit better, but he was moving and he wanted to do something else. So that's where he started on the off-label Otezla. So with this recent flare he had 2 or 3 months ago, I think he was seen by both endocrinology and urology at Vanderbilt. And I don't know if he's going to be starting on supplementation or not, but that was one of the cardinal signs many, many years ago when there was no treatment for Hansen's disease in men, was the development of gynecomastia because they had complete testicular failure and the estrogen kind of took over. So that gynecomastia is a stigmata that we don't really see much anymore, but that was not uncommon in men with Hansen's disease in the old days. So kind of interesting. There. So again, what we're talking about is that the presentation of Hansen's disease can be very, very variable, and we'll look at pictures. The most definitive tools that we have are the punch biopsy as well as the slit skin smears, which we'll talk about. EMG data is really helpful as well, if we can get that done, and ultrasonography we just talked about. So skin biopsy, it's important that you alert the pathologist that you're concerned about Hansen's disease. It's easy as well. Either, I don't know if they do it at UCSD, but we can send tissue to Baton Rouge to do PCR testing as well, especially with those patients where you're very clinically suspicious, but you haven't been able to prove it. Also, part of a good exam in a Hansen's patient is not just looking at skin lesions, but the palpation of nerves. Especially what's interesting is that the nerves which are adjacent to where they have a plaque of Hansen's are the ones that tend to be inflamed. So if they have a large plaque on their left face, that the nerve there, the greater radicular nerve, tends to be enlarged or inflamed as well. So the slit smears are done. I'm proud to say that our nurses do them very well. The nurse in LA doesn't want to do them, so they send patients down to us to do them. It's pretty straightforward. Basically, you take a really small slit, and again, from the coldest parts of the body, so elbows, knees, and earlobes, and you plate that out. It's dried, and it gets sent to Baton Rouge. And nowadays, we're sending a paired specimen to Brian Hines as well. And basically this helps us, especially in those patients where we cannot make a diagnosis based on a skin biopsy. If their smears are positive, that helps as well. Also, it really helps us understand how great is their bacterial load, because what we expect is that as their bacterial load, as they take their drugs, the bacterial load should go down and down and down. So the BI should go down by at least 1 point a year, if not more. So if you see in those patients where it's not going down at all, the concern is either that they're not taking their medications or if they have developed dapsone resistance. It's also nice for patients that they're taking all these pills all the time, and we can show them a concrete number that it's getting better. So briefly, in terms of the PB patients, may have just a few small lesions, which are usually anesthetic or hypostatic, and can be super subtle, like just this one patch on the thigh. We had a 9-year-old boy a few years ago whose family had been on a medical mission to Nepal, and the dad had some questionable symptoms, and he had one little patch of what looked like P. alba on his face, which we did a smear from and confirmed the diagnosis. So the PB patients can be really, really subtle. And this could be, this could be MF, it could be all kinds of different things. Multibacillary patients, it's different. They have a lot of bacilli, a lot of plaques, and they usually have other organ involvement. But if you look at this patient, I mean, this could be partially treated psoriasis, it could be anything different. So the key thing really is, are they from an endemic area? Are these plaques unusual? Are they numb? Do the patients have any enlarged nerves, any other neurologic symptoms? And this is pretty subtle sometimes. And obviously a really advanced case here. So I want to kind of keep track of our time so we don't run over here, but I think reversal reactions are part of what makes the treatment of these patients somewhat complicated. So basically, if you think of it, when you give somebody rifampin and they've had millions of bacilli in their body for several years, you then create a lot of foreign bodies, and these bacilli are in the skin, they're in the nerve sheath, et cetera. And so they create an immune complex, and you can basically get two types of reactions. And I think when I first started doing this many years ago, I thought, oh, nobody gets a reaction. And now I'm pretty much everybody's going to get a reaction, just don't know when. So I think the part about reactions that's very interesting is that they can happen within 1 week of therapy, or they can be on pills for a year, and then all of a sudden they get a reaction. So type 1 reactions are thought to be more mild. They just get some joint inflammation sometimes, and a few plaques get somewhat inflamed. On a very mild type 1 reaction, sometimes non-steroidals will work. Otherwise, they're on steroids. The main thing that we feel in our clinic is that if a skin lesion is inflamed, it's most likely that there's inflammation in the nerve sheath as well. And it's that nerve inflammation that we try to prevent so that we have a decreased risk of some permanent sensory loss, et cetera. We talked a little bit about upgrading and downgrading reactions. I think this is very interesting as well. So, we had a patient a few years ago who had CLL and was being treated with MDT and did fine, and then was given some therapy for their CLL and then reconstituted to having a normal immune system, and then they developed a reaction. You can also see upgrading and downgrading reactions in women in pregnancy. So standard treatment for type 1 reactions are oral steroids. We usually start very high. So we'll start usually at 1 milligram per kilogram if it's a bad type 1 reaction. These patients, the issue is that they respond really well to steroids, but the problem that we have is that when we start tapering them, it can be very, very delicate. So you can get them down to 20, then you go from 20 to 17 and a half, and they start flaring up again. And so then you do 20, alternate with 17. So some of these people, it may take a year, 6 months to get them off of their steroids. And sometimes you can just not get them off of their steroids. So the other things that we do in those situations where we can't get them off their steroids is, one of the things that we can simply do is we increase their clofazimine dose, because that works as an anti-inflammatory. And for some patients, that's one of the things that seems to be helpful. But like with your other dermatology patients, we run into problems all the time by causing comorbidities by giving older people large doses of steroids. Type 2 reactions are more serious. These can again happen during any course of therapy, and these patients are usually systemically ill. So they have fever, chills, their fever can get a high 104, 105. They can have organ involvement. And these are kind of the classic patients that show up in the ER and nobody really knows what's going on. And it creates great panic when they have that diagnosis of Hansen's disease. For these patients with severe reversal reactions, we usually try quite high doses of steroids in the beginning, but for most patients with type 2 reactions, steroids, even like at 100 a day, do not work adequately. And that's where thalidomide comes in and can be a lifesaver for these patients. So we'll talk a little bit about that. I think the other thing is, I think our nurses know as well, is I counsel my patients now that you may get a rash in the next few weeks or months. Don't automatically assume that that rash is a reaction to an allergic reaction to the medications. You could be having a reversal reaction. So we always want to get a good history, and we always want to have the patients come in when they say they have a new rash after starting therapy to try to figure out what it is. You know, the normal issue is that it's a reversal reaction. We treat the reaction, but they are to continue their antibiotics. The other thing that's interesting is that, you know, even after patients complete their MDT therapy, like the patient that Erik presented, you know, he completed his antibiotics 2 or 3 years ago, but he's still having reversal reaction after that time period. So many times the reactions persist after they're done with their antibiotics. So this just talks about thalidomide dosing, prednisone dosing, and how we do it for severe reactions. I think part of the issue is that there's certain parts of the world where you do not have access to thalidomide. And so in certain parts of India, for example, they're giving people huge doses of prednisone and methotrexate and other medications to try to get these reactions under control. Thalidomide has, you know, kind of a dark history, but for these patients who are febrile, nodules everywhere, you know, it's amazing with maybe just 2 or 3 days of thalidomide, they can pretty much return back to normal. And thalidomide, as you know, is thought to be related to TNF activation. So that's how thalidomide works. I think we all know that thalidomide is obviously very teratogenic. And so there's a registration program for thalidomide, which is very similar to iPledge, but it's a little bit more because thalidomide is also found in semen. So male patients taking thalidomide also have to sign up for the system and agree to wear condoms, etc. I just want to check time-wise. I'm just going to go over a few more slides. I don't want to go over here. But basically what we're trying to do is make an early diagnosis to prevent disability. And then the different complications of leprosy, which we talked about. I think it's important to remember that these patients who have shortened fingers, et cetera, it's not that the leprosy bacilli are in the fingers. What it is that the bacilli are in the nerves, which cause the hands to be numb, and repeated trauma causes this bony reabsorption. Hansen's complications, we talked about that. We just had a patient in the hospital at UCSD, and I want to thank Umber for helping me with that patient over the weekend, who fortunately is doing better, but these can be quite bad. A lot of these patients, it's bony reabsorption in addition to amputations necessitated by osteomyelitis. These are chronic classic ulcers which develop in these patients because they have insensate feet. So we work on and try to get those to heal. And we have obviously ocular complications, which is a whole nother issue. So that's another organ system that can be quite involved with Hansen's disease. So at this point, I'll take a little bit of break. Are there any questions from the audience at this point about anything? Hello?
Hello. Oh, sorry.
No, any questions?
I have a question.
Yeah.
How contagious is it, and what kind of precautions, like droplet or contact precautions, should we be employing when we see a patient we suspect with Hansen disease?
Yeah. So theoretically, if it's through a respiratory route, but you have to have really close, prolonged contact with a patient to get this. What we usually do in our office, especially with a new patient, is we make sure that they wear a mask. And then, we don't do any special gowning or anything like that. We'll wear a mask and gloves. But unless the patient has a really high bacterial load and has a lot of nasal symptoms, there is not any significant concern for transmission. So with that patient who was just admitted to the hospital UCSD last weekend, where he had treated Hansen's disease, I always try to make a furtive attempt to get a hold of the people in the ER, because if they hear Hansen's disease, they gown up, they put these patients in isolation, et cetera. So our standard protocol is for new patients that they wear a mask, we wear a mask until we figure out what's going on with them. But other than that, I don't think there's anything special that needs to be done. And also remember that for these patients, if they've taken rifampin for a few days and they come back for follow-up, we don't normally take any special precautions. So I think that's part of it. And I think that's one of the things that Umber was trying to help me with over the weekend is you just have to be really careful, because I've had patients who show up to the ER for whatever, they're having a heart attack, but somehow it comes up in their medical history that they had Hansen's disease 8 years ago, and the whole ER just shuts down and people go crazy. So we are cautious, but the contagious nature of this disease is quite low. Any other questions?
And we do have one comment in the chat too.
What's that?
So Dr. Boyko, she says, I had a 4-year-old girl who was given thalidomide for atopic dermatitis in Mexico a few years ago, and it seems to be easily available with little restriction there.
Yep. It's kind of unfortunate. I think that some countries in the world, like I think in Nepal and India, they just don't provide it anymore because there's not really any specific testing that's done. But in this country, it's very, very tightly controlled. The other thing I'm just going to say briefly. So the way our clinic is set up is that there are about 15 Hansen's disease clinics throughout the US. Most major metropolitan centers have a Hansen's disease clinic. That care, for the most part, is provided through our national program. So patients do not receive a bill when they come to clinic. Their medications are provided for free if they need special shoes, or in a severe case where they have to go to Baton Rouge and have surgery on their hands or tendon transfers, et cetera. All of that stuff is covered. I think we have a kind of an unwritten deal with most of the derm providers in town that we're happy to see any patient or a patient where they really are suspicious, but they haven't been able to prove it and they need us to do smears. And in exchange for that, if the patient needs, I don't know, something expensive done like a bone density or a quantiferon, that the doctor at Sharp or Kaiser will do that for us. But the services that we do provide for our patients are free of charge through the national program. Good. Any other questions? Okay. And I think 11 o'clock is when we stop. Is that correct? Okay, perfect. Okay, next time we'll talk about my trip to India, which was super interesting. I appreciate your attention. Again, appreciate UCSD's support of this program. I love it when the residents come. I think it's a super interesting and educational experience for them. So keep coming, and I appreciate UCSD's support of our program.
Eric, thank you very much. This is Rich. Really appreciate you spending the time. I know it's a weird experience giving a lecture to your laptop on your desk. Special
That's
appreciation.
okay. No problem. Appreciate it.
Welcome person here anytime.
Thank you. All right. Thank you, guys. Thank you, Alik.
Thank you, everyone.
Bye, guys.